시청자 여러분, 안녕하십니까? TVK에서 현대의학 특집을 담당하고 있는 UCLA 임상조 교수이며 신경내과 전문의인 전희택입니다. 오늘은 오랫동안 UCLA와 하버드 대학에서 외과와 이비인후과 수련을 받으시고 현재 UCLA 대학병원에서 임상조 교수를 하시고 계신 닥터 퀸튼 고펜 박사님을 모시고 요즘 획기적인 성과를 얻고 있는 전자청신경 이식术, 즉 다시 말해서 Electronic Cochlear Implant에 대해서 말씀을 듣겠습니다. Dr. Gopen, so you've been doing cochlear implant. To me, it looks like you're implanting artificial ear. Is that comparable? What do you think?
Sure. Essentially, that's correct. So cochlear implants are indicated for patients that have lost all of their hearing, and this is a way with a device that's placed surgically that we can restore their hearing. So in a sense, it is taking over the function of the normal hearing ear.
So it's like we're creating, implanting artificial ear. Is that correct?
Exactly, that's right. So at its inception, it was a very crude device, but as technology has advanced, it has become very sophisticated, and it can restore very close to normal, if not normal, hearing in the vast majority of people that get implanted.
That's amazing. So how long has it been going on? When was the first time they implanted Cochlear?
That's a very good question. So people understood the concepts of how hearing worked, and so they tried to electrically stimulate hearing as early as in the mid-1700s when they developed an electric capacitor. And obviously that didn't work so good. People heard a loud boom, but that was about it. And so the real modern day cochlear implant was first at its inception implanted in about the 1960s. So 1961, a guy named Dr. House was able to successfully implant some patients. And that evolved to be a commercially applicable device in about the late 1970s.
You mentioned Dr. House. That makes me to remember old days. In 1970s, I did moonlighting here in Los Angeles at St. Vincent. I spent 2 years as a moonlight night physician. And when I make round in his neurosurgical unit, I saw a lot of patients who had posterior cerebellar tumors, acoustic tumors and CP angle tumors. And I heard that he sometimes implanted early crude kind of a hearing aid device when patients lose hearing sensations completely. Is that true?
I think certainly at the beginning, cochlear implants were not well accepted. It was very controversial. There was a lot of arguing about how well they could work, and so very world famous neurophysiologists were saying, there's no way this can work. Why are you wasting time? Why are you harming patients by doing this? But I think a number of factors have shown that cochlear implants have become quite successful, and part of that has been the drive of technology. As computers have become more sophisticated and more advanced, and electronics have become more miniaturized, we've been able to overcome a lot of the obstacles that prevented the early initial cochlear implants from being the crude devices that they are to now very sophisticated devices that work quite well.
For my general audience, I want to clarify that cochlear means the snail in the English, in the common word, right?
Yeah, exactly.
Snail. The reason we call that cochlear is our inner ear is similar to the shape of a snail. Is that correct?
Exactly right. The organ of hearing itself is coiled 2 3/4 times. It looks much like a snail. So that cochlea is where the sound waves, which are mechanical, are transformed into an electrical signal that the brain can understand.
So cochlear is old Latin word. Is that true?
I think so, yes.
Right. So now you can put a lot of scientific device in the brain. For instance, 2 months ago, I did a medical talk show regarding deep brain stimulation implant with Dr. Paradian at UCLA that cures Parkinson's disease. Not necessarily cures, but abolishes the symptoms so dramatically, especially with the tremors and difficulty ambulating and unsteadiness. And this device you're implanting is like a combination of the microchips contains a lot of electrode, and you also implant sound processors, transmitters, microphones. All these things go inside the ear. Is that true?
Sure, sure. I can show you if you'd like. We can go over this, this is what actually gets implanted inside of the patient.
That goes inside the ear?
It goes underneath the skin, kind of above and behind the ear. So it would be sort of in this region of your head, through an incision that goes behind the ear and a little bit up onto the scalp. This device has the electrode, which would be a little tiny metal array that goes down into the cochlea. So that's the electrode part.
And so all the way to the inner ear.
That's right. So you drill a little opening into the inner ear, and you gently insert this little coiled, and you can see it has a little tiny coil on the end of it there that's going to go down into the cochlea and make those turns, the 2 3/4 turns. This is a lot of the computer technology processing, and then there's a magnet that allows the external part, which would be here. So this part is worn externally behind the ear, and this is a magnet that connects and talks to the part that's surgically implanted underneath the skin.
Okay, so let me just show this the model to our audience. This is the inside the ear. We call that inner ear. Is that right?
It has if going from the outside in, the external ear canal.
This is external ear.
Right, external ear. The external ear canal would be the.
And so this one goes behind the ear. Is that right?
Right, exactly.
Like
it
this.
hangs under, just like a hearing aid would hang on. That's right.
And this connects the outside and stimulate the magnet. And this actually goes inside here somewhere.
Exactly right. Yes.
Okay. So this means the microchips and sound processors and microphones all go inside the ear.
Part of it is underneath the skin.
Except this one.
Right. There is an advantage to having an externally worn devices. Number one is you can upgrade that. So as computers get better and technology gets better and processing of sound gets better, you can take advantage without actually doing another surgery and removing the device, and you can incorporate all that advanced technology into that part. So there are parts of the processing that's done outside, and also the microphone. It gives you more natural hearing to be able to put it close to where the ear is and pick up the sounds in that manner.
So you have to have fairly good hearing nerve intact. Is that right? I mean, in order to receive all this the stimulations and the impulses, electrical
That's
impulses.
right. So if someone had their nerve cut or severed, a cochlear implant would not be of any benefit because it needs that nerve to be able to send the signals up into the brain. But the majority of people, when they lose their hearing, they lose it because of those little cells that are inside the cochlea. And that we can overcome with the cochlear implant very, very easily. As a general rule, if you've been deprived of sound for more than a year, the nerve will atrophy and wither away. So let's say that you were born deaf and you didn't do anything for 20 years, well, the cochlear implant won't be very helpful because the nerve has withered away and died. So you are a little bit under the time gun for implanting someone if they've lost their hearing. About a year is a rough number.
Okay. So before we go too far, what else goes to inside the body? You have to have a microphone, is that right?
Well, the microphone is usually attached to the external part that you wear. So underneath the skin, you're going to have a magnet, so that
So what's the purpose of microphone?
to pick up the sounds that are being, as I'm talking to you, the sound waves that are.
So microphone picks up the sound.
Correct.
And then next it goes to the processor.
That's right.
The
So
sound processor. What does sound processor do?
It's taking all these sounds and triaging them so that they can be delivered to the device appropriately, so that they can strengthen the signals that they want and try and get rid of the signals that they don't want. Your normal ear will do that for you, right? So you can focus on sounds that you're more interested in listening to and try and kind of tune out the background noise. It's very difficult to do that with programming, but there are certainly some sophisticated programs.
So you will need the type of transmitter to send it to the nerve.
Right. So that's the final three steps. Well, let's just take a step back. So initially, it's going to be received by the microphone.
Okay.
It's going to be processed and sort of prepared, and then there's going to be transmitted to the under the skin part, right? And so the under the skin part has a receiver to receive the processed signal, and then it has the final part, which is the electrode that's going to be down into the cochlea to deliver the sound to the nerves.
So the voice, the speech we talk is manufactured, created by the vocal cord.
Yes.
Is that right?
Correct.
So unless someone picks this up and analyze, process it, otherwise it doesn't mean anything. Brain cannot receive that as a speech. Is that right?
Well, hearing aids are a device that's just going to amplify sounds, right? So
right.
If you can't hear them because you've lost a little volume, the hearing aid can overcome that. But a cochlear implant works in a very, very different way.
Right.
They're not just amplifying the sounds louder. What they're doing is they're taking the sounds and they're converting it to electrical signals that your brain can understand.
And that's what speech.
Exactly. And that's what the natural organ does for you, right?
Right.
Your cochlea takes those sound waves and changes them into an electrical signal that the brain can understand.
Isn't that amazing that our brain is doing that already? All these computers and microchips and processors doing with so much gadgets and difficulties, our brain just does that instantly.
That's right, absolutely.
Okay, so you send the signals to the where next process is what?
So the cochlea is actually organized spatially so that each frequency is at a different point along the cochlea. And so with the electrode, you can actually program different frequencies to be naturally where they would be along the course of the cochlea. And that's one reason why the cochlear implant works so good is this processing technology can deliver different frequencies by electric currents to different points along the electrode array and really restore natural hearing. It really does take over the natural hearing ear's function.
That's fine, delicate processing.
Absolutely.
You're doing with this device, replacing the natural hearing process that we already have.
Right. But as you said, it does depend on a fairly healthy nerve. If the nerve is not working so good, then the cochlear implant won't really restore the hearing.
Okay. So who are the best candidates for the cochlear implant?
Sure. So any patient that has lost their hearing can potentially benefit as long as they haven't had that issue with the nerve deteriorating over time. So if you're, say, 70 years old and you've lost your hearing in the last year or so, nothing wrong with implanting. That person will do very well and have a very good outcome. If you're born without hearing, usually you want to get to those children as soon as possible. So as early as about a year or two is ideal, and they usually have a very good result. If you wait too long, if you're born deaf, then you're going to lose that nerve, and patients won't be as benefit from the cochlear implant.
So what's the time limits? Is that 2 years old or 3 years old, 5 years old?
It depends. If they've had even a little bit of residual hearing, that can help. So sometimes you can implant someone that was born.
In general?
Yeah, usually a couple years of sound deprivation starts to kind of make the nerve not as healthy. So you like to get to most patients within a few years of them losing all of their hearing. But if they have even a little bit of residual hearing, then you can certainly push that back. So we implant all ages. So there's no age criteria. I've implanted people as young as 11 months and as old as 95, I think, is the oldest patient I implanted.
But what about a person born completely deaf, without any reception or ability to making sound, complete sensory neural deaf, are they become eventually a candidate for this implant?
Sure, they're probably our best candidates because you can restore their hearing quite reliably as long as they don't have any problem with the nerve not being formed properly.
But if you're born completely deaf, isn't the auditory nerve becomes atrophies?
It will over time. So that's right. If you wait too long, if you wait till they're, say, 10 years old, then there's no real chance it's going to work.
Okay.
But the brain is very plastic. It's looking for those signals. And if you give it those signals within the first few years of life, it will robustly incorporate those into the
brain
the
adapts to it.
Absolutely. Very, very well. In fact, I think that has surpassed even the most optimistic forecast back when these were being first designed.
So what about, let's say someone is 30 years old and with some kind of trauma, you lost your hearing ability completely. What are the chances of his hearings come back reasonably?
It would be a very good solution for that person. It depends somewhat on how they lost their hearing. If it was from say a car accident where the nerve was severed, then that patient wouldn't have any benefit. But if it was from a toxic drug that they took possibly, or some exposure from chemotherapy agents or something that destroyed the organ of hearing, then those people would do very nicely with the cochlear implant.
So as long as your hearing nerve is intact or not severely damaged, then they are good candidates for this kind of implant surgery.
Exactly.
So what it actually requires is someone is going to have the surgery. How long do they stay in the hospital? How long the surgery takes? Can you elaborate a little bit?
So the surgery takes about 3 hours to perform. It is done with an incision that goes behind the ear and a little bit onto the scalp. The device is placed. The risks of that surgery are fairly minimal. There are some risks with infection, bleeding, some of the nerve structures that are in that area. But as a general rule, the risks are fairly reasonable. It is not a terribly invasive surgery, so people do not have a lot of pain after the surgery. Some of them have some dizziness, and that can be variable depending on how much residual balance function the ear had. But as a general rule, it's an outpatient surgery, so you don't need to spend the night in the hospital. It gets activated usually around a month or two after the procedure, and when it's first turned on, it doesn't sound very good. There is a lot of post-operative what's called mapping, which is essentially programming of the device to the patient's individual needs to get it so that it's working really well and the sound quality is...
Is that because everybody's different with their perception of the sound?
Sure, that's right. The nerve is requires a little more stimulus. Maybe the electrode is a little further away. You have to give a little more current. All that stuff is optimized after the surgery to give them the best and most robust responses to make their hearing as natural as possible.
That's why these patients requires go through very close follow-up with the specialist of the sound. It's called audiologist.
Right. So there are specialized audiologists that are in charge of taking over the care of the patient after they get implanted to program the device, and that process is called mapping.
So you need a continuous audiological therapy.
Yes, it's very intense.
Rehabilitation, more or less.
It's a crucial part. The implant really that's the most important part of this whole successful implantation, is that they have the appropriate mapping done by an experienced audiologist.
So you mentioned you don't expect much post-op complications. If anything, do you have any symptoms relating to other parts of the inner ear, like a vestibule that controls your equilibrium, and does it affect any of the labyrinthine symptoms?
I mean, the organ, the inner ear organ does subserve both balance and hearing. And so whenever you're manipulating that, you run the risk of injuring some of the residual balance. Some of these patients have very little residual balance, but they can be dizzy either temporarily or long term, especially the patients that get bilateral, meaning both sides are implanted at the same time. When you have an acute change in both ears, the opposite ear can't compensate, and those people can be dizzier and have a harder time with it. There are other nerves in the area that are in charge of taste, and so some people may complain of a little taste disturbance after the surgery that usually goes away with time. And then there's a big nerve that moves the face, and sometimes the electrical current, instead of going to the inner ear where we want it to restore hearing, it can go to the facial nerve, and they can actually get some twitching or movements of their face, and that's suboptimal, and usually you can reprogram the electrode to stop doing that.
So there are some mild side effects, but mostly temporary, nothing permanent to be.
Any surgery has risks, obviously, and there are no guarantees, but the majority of people do very nicely and have a good result, yes.
Okay. I hear some controversies. Is more sociological thing. From sign language users and implant users. The sign language people was concerned whether there's another group of people threatened by the hearing community, so-called, by creating this post-implant not completely comparable with the hearing, but creating some kind of a minority. In other words, cultural minority against the hearing community. What do you feel about that?
Well, certainly I think you're right. There's some controversy about cochlear implants, particularly in regards to the deaf community, and I think that has maybe changed over the course of the 30 years or so since implants have become more prevalent. But there are certainly individuals that don't feel that hearing loss is really a disability and doesn't really need to be treated, and you can certainly envision certain individuals that are wearing implants and other ones that have chosen not to. There might be some issues with those sorts of things, but it's you know,
most patients are very satisfied after the implant. Is that true?
There's certainly a fraction of people that end up not getting enough benefit to use it, and they actually stop wearing it or even have it removed. But I would say it's a pretty small minority at this point. Part of that is because we're fairly good about preparing patients for what it's going to be like. There's a pretty rigorous screening process and panels of people that all kind of interview various candidates and explain to them what they should expect and what it's going to be like. And so you would hope that the individuals that aren't so interested are not going to go through that, or at least are going to be educated enough that they realize it's not something for them. So by the time you're getting to the stages of getting surgery, most people, I think, know what they're getting into, what it's going to do for them, and minimizes that sort of outcome where the person's not really happy or not using the device.
So in general, patients are happy after the surgery?
Absolutely, yes.
Last but the least, what about the health insurance coverage? Is this fairly expensive procedure covered by the health insurance in our nation, in America?
It is, yes. I mean, they have criteria for how much hearing loss you have to have before you qualify for it, but as a general rule, if your hearing loss is deemed appropriate for a cochlear implantation, it will be covered, the device as well as the surgery, and that's something that I think is fairly universal across most states.
Okay, thank you very much.
You're very welcome.
It was very helpful. 시청자 여러분, 많은 도움이 되셨으리라 생각합니다. 자세한 것은 주치의와 상의해 주시기 바라며 오늘은 여기서 그치고 다음 시간에 또 찾아뵙겠습니다. 안녕히 계십시오.